Good afternoon all. My paper is on 2-year visual outcomes of anti-VEGF treatment of diabetic macular edema in a tertiary care hospital. Diabetic macular edema represents a prevalent and disabling eye condition. Its prevalence in diabetes is 5% in 5 years and 15% in 15 years. OCT, being a non-invasive, non-contact imaging modality, plays a crucial role in the early diagnosis of macular edema and for deciding the treatment. Vascular endothelial growth factor has a crucial role in pathogenesis of diabetic macular edema, and now it is preferred as a first-line treatment for the same. My aim of the study is to study the 2-year visual outcomes of anti-VEGF treatment of DME in a tertiary care hospital. Coming to materials and methods, it's a retrospective study that took place in Rio SCB MCH Cuttack for a period of August 2020 to 2022. And the medical samples were taken from the medical records of 200 diabetic macular edema patients. After considering the inclusion and exclusion criteria, 120 patients were included. Those patients were having incomplete ophthalmological data, significant vitreomacular traction, macular scar, or any previous laser were excluded from the study. The method of evaluation includes the complete ophthalmological examination at the first visit, along with OCT and complete blood investigation. The participants received 3 consecutive injections of ranibizumab 0.5 mg at the first 3 visits, that is from 0, 1, and 2 months. This is the image of a patient of diabetic macular edema receiving intravitreal anti-VEGFs in our setup. Coming to the results, in our study, we found the patient aged between 51 to 60 years has a more prevalence of diabetic retinopathy, that is 55%. There is a female preponderance, and incidence of diabetic macular edema with duration of less than 5 years was 28%, in 5 to 10 years was 52%, and in 10 to 20 years was 20%. 22% of patients were having mild NPDR, 45% were having moderate NPDR, and 33% were having severe NPDR and early PDR. In our study, we found the spongiform pattern of CSME was most common, followed by cystoid macular edema, and then CME with serous detachment and posterior hilar traction. At the time of presentation, 12 patients were having best corrected visual acuity of 6 by 6 to 6.9, 36 were having 6 by 12 to 6.18, and 72 number of patients were having best corrected visual acuity of less than 6 by 24. After receiving intravitreal injection, BCVA gain at the end of 12 months, the VA gain of more than 2 lines were 25%, and 34.9% were having VA gain of more than 3 lines. At the end of 24 months, 14% of patients were having a VA gain of more than 2 lines, and 19.3% of patients were having more than 3 lines of visual acuity gain. At the time of presentation, CMT measured by OCT, there were 29% of patients were having in the range of 270 to 351 micron, and 50% were in the range of 351 to 500 micron, and 21% were having in more than 500 micron central macular thickness. After receiving intravitreal injection at the end of 2 years, there was seen a significant reduction of central macular thickness. At last, we conclude that BCVA gain of more than 2 lines and 3 lines at the end of 1 year and 2 years was statistically significant. There were significant improvements in macular edema were noted on OCT. Eon et al., Kwang Dong et al., and Datta et al. Was some studies that found the similar results, which was in accordance to our studies. At last, we conclude that our analysis shows the effectiveness of anti-VEGF treatment in diabetic macular edema patients, and more intensive treatment should be implemented in the management of patients in order to achieve a better visual outcomes. These are my references. Thank you.